Hi, everybody. My name is Paolo Cassano. Today is October 7, 22. Welcome to the MGH brain-PBM clinic rounds. It is my great pleasure to host today Dr. Lew Lim, CEO and founder of Vielight, who is coming in today to give us a second round of presentation over treating acute COVID-19 with photobiomodulation, clinical trial results, and the prospects for the long haul. Lew, thank you for coming in again. We are eager I know you plan on a small recap and update, and we're eager to get it to a discussion and get everybody to ask their questions as well. Take it away.
Okay, well, thanks for the invite again. I think we had more people last time, and there are a few people I don't recognize, but happy to meet you. So we kind of remain in context. I just want to, do a quick recap. I'm not covering everything from last week, but to so that we can lead on to a discussion. Right. I was talking about basically what we found in our acute COVID-19 study and how is it looking for a follow-up long COVID study. And this was the device used, circle the intranasal and one to the chest, which is really on the sternum, activating bone marrow, releasing stem cell maturation into the thymus, and also to irradiate the lung and hopefully help with recovery of damage to the tissues and say the endothelial cells. We did a preprint. We actually haven't done a submission to a targeted journal yet for our own reasons, but you can find detailed information there. Very quickly, we looked at a number of endpoints. Our primary outcome is really generally how we use a scale called the Wisconsin WURSS, which is the Wisconsin Upper Respiratory Syndrome Survey, and basically how sick do you feel today as a primary endpoint. We found significance for those who have 0 to 7 days of symptoms, and we screen for those who have reported basically moderate to severe symptoms, so we are able to measure the improvements. We use the Kaplan-Meier method, which is quite commonly used, and also the Cox proportional hazards model and the Kaplan-Meier method, there's usually always a graph that looks like this. And we want to see the significance of the treatments over 30 days versus control, and we saw significance. Now, when we go to the secondary endpoints, we found a number of symptoms that show significant improvements. And what is relevant for us in moving forward is look at these various symptoms, and we decided that what seemed to work for our protocol was thinking clearly or pointing to brain fog. The other symptom that relates to your brain was headache, but and for various reasons I explained 2 weeks ago, brain fog is our choice to move forward. Now, if you recall, a couple of weeks ago, President Biden declared that the COVID pandemic is over. Then the next day, I don't know how they managed to mobilize so quickly. It just shows the number of people who are in desperation and say, look, don't forget us, we're still fighting long COVID. It is still going on. Actually, they haven't forgotten them because the initiative by the US government of, allocating 1.5 billion in trying to recruit like 40,000 people or something in the study is still going on. But the point is, long COVID seems to be still here, and a lot of people are still suffering. So there is obviously, they're not able to physically be like themselves before. But we want to look at brain fog, and in the context of everything, there's a whole bunch of symptoms. Apparently there are 200 of them. These are the significant ones that are listed by CDC. And thinking clearly, concentrating, brain fog is one of the significant ones. Actually, recent information showed that the loss or the loss of smell and taste is still going on for a lot of people. So that is the other significant one that's being presented in recent publication. Now, the various theories about long COVID, there is this theory about the virus migrating to the brain from the nose, going past the cribriform plate, olfactory, and this all connected to the brain. There's the vasculature routes when even you hit the cytokines and you hit. Well, there's a possibility of the virus going in from the other parts of the body through the circulatory system, past the blood-brain barrier into the brain, and there is the choroid plexus discussion, which is really the separation between the circulatory system and the CSF, cerebral spinal fluid. So there is these various other theories, and but inflammations to be taken whole, right? Just in summary, we were talking about, especially those who have experienced severe conditions out of this infection, and it's starting to lead to the immune system playing a more and more prominent role, and this discussion about autoimmunity seems to be building up. So there is this study that actually is more like reviewing the literature and suggesting that if you can help to attenuate this activity of the cytokines, reduce the effects of neuroinflammation cytokines, the activation of microglia, which actually lead to the building up of the other cytokines. You can also help to reduce the effect on the hypothalamus, which leads to systemic symptoms. They are suggesting luteolin, which is actually a derivative from olive oil, I think, to carry that. Well, the extracts from plants, I forget the name for it. Anyway, they're suggesting that this may be an answer for it. Now, so there's evidence showing that long COVID is associated with inflammation. There's literature that they pointed to which affected the inflammation of olfactory bulb, the medulla, the brainstem, cerebellum, but they're showing that actually is widespread. So this is imaging. There's a PET imaging is hard and expensive to do, so they only had one, so it wasn't saying very much. But we had more coming. This is a modeling proteomics looking at the influence of the genes, and suggesting that the markers that this is showing is starting to look like Alzheimer's disease. So there's similarities between them. Now, this was actually just published after my presentation. This is a big one. It is actually coming out of Brazil. Now, they look at a number of investigators. It looks like, I haven't counted them, but it looks more than 100. So it involved a lot of research institutions in Brazil. But what I found really interesting was it was edited by Marcus Reikler. I think Mani recognized the name. He was the person who coined the default mode network. So I respect his work actually quite a lot. And now what they found was I guess a big study. They look at all kinds of things. They look at look at autopsies of people who died from COVID. They look at healthy brains and what they're looking at, what they found. I think they try to zero in on the viral load and see where it is found. But there's some new information. My last presentation, I said there seems to be some evidence of viral load in the brain, but not a lot. And this is still it. They had 26 post-mortem studies, people who died from COVID. They did autopsies and found that where they found damage to the brain, they also found viral load. So 5 out of 26 people actually presented this. So there's viral load in the brain. Somehow some viruses got into the brain, not everybody, some people, and they contributed, or they're linked, at least linked to evidence of damage to the brain. Now they found the proteins, looked at various nuclei and brain cells, and found the traces of the viruses are found most in the astrocytes. And astrocytes is in the brain is, it's a glial cell that contributes to metabolism, your neurons and so on. So without the function of astrocytes, you're going to experience things like fatigue, mental fatigue. They found, those, I think among 81 people in malinfection, they actually see atrophy in the cortical thickness too. So there's nothing to sniff. You really don't want to get infected with COVID-19 if possible. But this was done with the earlier variants, the more infectious one, like Delta. I think most of the studies were done at that time. Anyway, this is really interesting information because this has a extended effect into long COVID for mental fatigue and brain fog, I believe. Now I thought this slide would be interesting because it draws parallels between brain fog and Alzheimer's disease. So this is another big study. It's a really good study as well. And they brought up this about leakages in, this is like a filter, dealing with these inflammasomes, the cytokines, but there's leak and you get overactive calcium ion activity, and then it leads to the reaction for the mitochondria, more reactive oxygen species, and there's this cycle going on. And usually this particular protein was associated with pulmonary heart condition. Now, they suggest really you ought to look at the effect on the cognition as well. So it leads to phosphorylated tau, and they found that phosphorylation mainly in the cortex, the CTX cortex versus control, among the old and the young as well. So particularly old, and it's found in the cortex and the cerebellum. So we don't want to forget to look at improving the health of the cerebellum too. This was something that I showed last week is relatively new. This is, this study was published maybe 3 weeks ago, and a lot of the work has been done in Canada, between Toronto and Halifax, Nova Scotia. So what it's saying, it's long COVID, like Alzheimer's, they're proposing here, teaching us that Alzheimer's could be an autoimmune disease as well. They're showing similar markers, and you should not just look at beta amyloid, but also how it's linked to the autoimmune condition in your body. I did talk about very briefly about Biogen's drug. It seems they've got good results by way of slowing down the progression of Alzheimer's disease, like by 27%. So that's still subject to FDA review right now. And that is actually focused on the targeting beta amyloid, like the previous one. They did, it's still the same thing, but they did the study a little bit different. It's bigger sample, and the statistics model a little bit differently, and it saw improvement by 27%. But who knows if they have targeted a way to affect the immune system, recognizing it as the autoimmune system, maybe they get better results. Now, this was actually literally also about 2 weeks old. Traces of markers that lead to recognizing long COVID as an autoimmune disease was actually brought up in this study. And what we have in photobiomodulation, this one I found, and I thought it was again an important disease because this was an Iranian study, fairly recent, and the only one that I found that has been directed on humans, but they directed to the lung area, and found a decrease in the cytokines. So you're dealing with inflammatory factors here. Even though it reduced the good cytokine, which is the IL-10, there was more reduction over time in the ratio, or rather, the reduction in the ratio between IL-6 and IL-10 in this chart. So that suggests to us photobiomodulation can help in inflammation. I think that's very key, because now we're talking about long COVID associating with inflammatory factors and autoimmune, and if you can reduce the activity of the cytokines, you may see an improvement in your brain fog. This was a study that that was done to suggest that if you do, this lymphatic drainage intervention, you can see improvements in your COVID symptoms as well. This chart shows improvement in the men by 41% and women 60.5%. Now, this suggests that there are not a lot. This is only one I found that that ties the lymphatic system with long COVID, and we should ignore it now. There was some work done, some publications done. Some of you are here, I believe, on reviews. But basically, the main studies were done by Russian group on animals, if we can recall. It shows that photobiomodulation on the glymphatic system helps to actually improve your brain, which is basically this review study. So there's promises on lymphatic, and what we want to do is see if we can point to where we can help with the clearance of this stuff, unwanted stuff in your brain, or improve the circulation in your brain. to do that. Now I want to point out there's a difference between lymphatic and venous drainage, which is related to, take your blood circulation and removing when the venous activity is removing the unwanted stuff in your circulatory system. Now, when we put here, there are two spots. One is the confluence of sinuses. You can see, there's a big confluence, like a big railway junction. Here, I think if you pick one spot, that is a good spot. In the past, there has been discussion about emissary veins and all that. I thought this was pretty good. And here is also where there's quite a bit of activity in the glymphatic drainage as well in these areas. And when I'm not showing here, but when you point to the nose, you're also hopefully pointing to, some of the channels in your lymphatic system. Now, this is something new and fairly recent. And this relates to, oh no, why the red lines here? Anyway, to the gamma, the brainwave 40 hertz in your brain. Now, the presence of gamma in the brain is actually quite different between, here we talk about, so in the context of the elderly and Alzheimer's disease. So in a healthy young HY, the gamma mainly present, the peak is, around say 37.5 hertz, around 40 hertz. But as for healthy elderly, it seems to be shifting towards shorter wavelength. That is looking like, low gamma. And as for Alzheimer's disease, you're seeing actually the peak gamma in looking like high beta. So what this suggests is if you want to influence gamma, you want to try to restore the 40 hertz and maybe restore some of the losses to aging brain and Alzheimer's disease. Okay, I don't know where this red line come from. We have, this is just going back in summary, but looking at pointing this to the default mode network, the intranasal, and here's a key area to the top cerebellum, the glymphatic system, the confluence of the venous system, and we want to take this forward to a double-blind randomized clinical trial and use at home, do remote data collection. And now we're seeking collaborators. If any one of you here are interested, or your collaborators or people we're still looking for co-investigators for sites and recruitment resources. We are just about to start a pilot. It's going to be site-based, and after this, pending good results, and it will take time to get sites going. We want to then move on to bigger pivotal trial. So I'm opening out there. Talking about this, I did talk briefly with Paulo earlier about we also have a parallel Alzheimer's trial that's going. We've modified it for even better chance of success, and we're looking for site investigators. So maybe there's something to think about in our discussion. We have half an hour. Your experiences with long COVID. I'm focusing on long COVID, but we can talk about other things. With your personal experience and your practice, are you involved in long COVID research? There's something we can share. And what do you think is the outlook for COVID and other potential pandemic? So thank you.
Thank you so much, Lew. And I think this is an opportunity again for anyone to ask questions. And also, we're excited that you are launching the next phase of trials for Alzheimer's disease and long COVID. And this might be of interest to many. And so we definitely want to hear more about your studies, but we'll probably start with a round of questions. I see David already raising his hand. So go ahead.
Thank you, Paulo. And thank you, Dr. Lim, for this very comprehensive. I mean, again, another comprehensive information set. So regarding this kind of study in this elderly population, we have had a collaboration experience with Paulo before and ongoing. That there are two things that we notice in this elderly population. One is, of course, probably the difficulty in penetration, because their skull bone, maybe like the density would be slightly increased after this kind of aging in human. And then secondly, I'm not sure whether you're going to use like a in-office device, or you're going to use something wearable and home-based device. But we do found that this elderly generation this kind of technology thing can be a bit tricky for them and influence the application. What's your opinion or experience?
Yeah, we actually we also want to learn more about this. We our devices out there, we've got is used by a lot of elderly people. It seems to work, but it's anecdotal. And now I understand. I've seen your data on that. It seems to suggest the elderly. I don't know what it is. There was many years ago, there was a study that okay, the cranium doesn't matter, the bone it seems to go through, and like maybe it's something else. Maybe it's to do with the circulation. Maybe it has other indirect channel that's work better with younger people. There's nothing work with. Actually, there's I can share that I've seen papers that shows that that there is there are a lot of these little channels that link the scalp to the brain, and maybe that is maybe that's not as prominent in elderly people. But the bottom line is we want to learn more, and we're actually doing some work with Baycrest Hospital and see, other than EEG, which we see, we've done quite a lot of EEG, and I would say that the response from the brain of various people actually was quite immediate and quite pronounced with EEG. But we want to learn more through fMRI, and we're actually working with Baycrest Hospital in seeing. But one of our objectives is to see what parameters, the different parameters are pulsing and different wavelengths and all that. But the long COVID, this was actually discussed internally. Do we set an upper limit on the age? And I think Nazni, we're looking at 65, right? So I don't know if there's any effect, but we did talk about creating strata, okay, got to be like 18 above, maybe up to 18 to a certain age, and another next strata, and maybe we'll see differences in different age group. The bottom line is we are still learning, but we want to do the clinical trial anyway. So so having strata will help us to explain things better.
I mean, I agree with you that maybe bone density and this kind of application thing is not the only reason. There are probably other factors as well. But yeah, but we do found that it looks like the treatment effect in elderly population seems to be compared with younger generation or younger people, seems to be worse or not as efficient or not as helpful in this group of people.
Some other people here can share the experience.
I see Marvin.
Yeah, I certainly have seen that to the point about older and younger, the capacity for the person to make good use of the stimulation in terms of their increased or their effective neural communication. You know, as people get older, the interhemispheric communication in the EEG is becoming less and less efficient. And I think, as I've said before, that I think the photobiomodulation is most effective and most relevant as a tissue level intervention. And that if you combine that with an intervention that's going to enhance the efficacy or the efficiency of the neural connectivity, you're going to see a much better improvement overall. And that's certainly what we've seen, you know, in the work that we're doing now with the Neuradiant and with the Cognitolight and all the other technology that we've been using. We think it's important to combine an intervention that's going to enhance neural connectivity directly.
So Marvin, just a quick follow-up. So you're combining visible light and infrared light? We're
combining infrared 1070 light with brainwave neurofeedback training.
Okay. So I thought Cognito was about flickering light and sounds at 40 hertz. So it's a different intervention?
Yeah, that's certainly, we are using the photobiomodulation as an entrainment intervention, yes. And I think that whenever you pulse light on the scalp, you're entraining the EEG. I mean, Lew and I have discussed that, and we showed that in, what was it, Lew, 5-6 years ago, we showed that, you know, pulsing 10 hertz on the scalp with the Vielight immediately altered the global alpha propagation across the cortex, and that there was an attenuation when you turn the lights off. So yeah, that's quite clear and effective, but how you would then modulate and target the stimulation, the entrainment, in line with the benefit from the photobiomodulation, I think that's what really needs much more work. And that's what we're focused on now.
Nice. So any other questions so far? You know, I'm curious also about this upcoming studies. So I'll be curious to hear more about what are your plans, kind of broadly, what the studies look like, and what would be an ideal site for people to kind of reach out to you and possibly apply to become a site on your 2 or more studies, Lew. And I'm curious, on the line of what Marvin was saying, whether EEG will be an outcome measure, and whether there would be any type of personalization of the dose in the studies.
Maybe behind Nazanin, she is heavily involved in long COVID.
Yes.
How do you know it?
Hi, everyone, and Paulo, thanks for the good questions. So for this study, the long COVID pilot study that we're thinking right now, no, so EEG is not part of it. It's the setup is going to be absolutely virtual, remote. So we don't want anyone to come actually into any of the sites and do the visits and do the EEG stuff. The reason for that being is we ran our acute COVID study completely, absolutely virtual, and we built the infrastructure, and it gave us some results. So now we just want a quick, fast study on long COVID population of 34 subjects all over the US. And one site, just as a physical site for IRB's purposes, the central IRB's purposes, would be enough for us move on, but then everything, all the infrastructure is absolutely virtual. So we would have electronic data capture systems in place that we would do the screening, and we have a CRO. So we would set up patient visits virtually, remotely. So everything will be virtually. And as Lew was mentioning, so brain fog is one of the actual primary endpoints that we're looking into. We are using a couple of cognitive assessment questionnaires and also quality of life questionnaires, and maybe some symptomology questionnaires to check in with the subjects using our newest version of RX Gamma or Neuro Gamma with the fifth LED at the back. And the duration of use is going to be for 3 months. And then we will be doing the assessment after that to see what comes out of this study. Based on our results, then we will be designing quickly and then moving on to a pivotal study.
Thank you.
Yeah,
Oh, go ahead, Lew.
Yeah, so there are going to be two phases. One, we've been discussing with someone who will be the primary investigator for this pilot phase. 34, I think we can recruit 34, but I think when we move to the pivotal, it's likely to be over 200, maybe like what we did, we were targeting 280, last study all over. We had quite a number of investigators. So we have one primary who will look after safety issues and adverse events, but the other investigators have dual responsibilities. One is to help, and a lot of the patients are coming from them, so they are their patients as well, and they are also monitoring them and helping them to report the data. But we always need, in a proper clinical trial, we always need a CRO, which is a clinical research organization that put everything together, make sure the data are good, to liaise with all the investigators and stuff like that. And eventually, you have to clean up the data, you have to manage the data, and you'll be surprised how long it takes to go through that process to even start the final data analysis. It took us months. It's a lot of work.
I see there's a question from Steve.
Yes, hi, my name is Steve Rothman. I'm the Seattler. I'm a retired clinical psychologist. I did neurofeedback for probably 35 years, but I've had no experience with your devices. Lew, would you be kind enough to put the slide back up that had the results from your outcome study? Is that possible for you to do?
Yeah. So this one?
Yeah. Yes. Thank you.
I'm trying to share. I'm trying to do a slideshow. Maybe. Okay, let's just show this.
Yeah, I wondered what you made of the 8 to 12 day results there.
Okay.
It almost looks like there was perhaps some if I'm interpreting it right, some backsliding at 8 to 12 days. The difference being two.
Really, this is the thing about, it's a good thing in our protocol, we actually stratified. Now this is actually in our protocol, it's 8 to 5 days and 5 and 6 to 10 days, but we had to add 2 days for shipping and training before we actually, before the devices were actually in use. So we aligned control and active, and we really should be speaking about 0 to 7 days when they actually started, before they actually started using the treatment. Excuse me. Now we didn't see 8 to 12, which is very, very interesting. I can't explain it completely. Now, we reported that actually we saw the other way for a couple of symptoms. One is energy level and tiredness. And we were seeing it negative. Now, we can't fully explain it, except that when we looked at some of the other studies, we see that after 7 days, the endothelial damage was taking hold, particularly with the Delta variants. And it was a case that we, the way that we treated people may not actually deal with that, but it helped with the other symptoms too. Things like sneezing and headache and all that continue to improve. But for some reason, the level of energy were down. That affected the overall data actually for 8 to 12 days. So it actually ended up with a negative for us. So when we go and seek regulatory clearance, we are saying that we can only make claim that is going to help people with up to 7 days of symptoms and not longer than that. So that is, I think it's to do with the inflammatory, the cytokine storm taking place in the Delta variants that continue to progress, that even the way we try to help with photobiomodulation did not, although I can come up with theories why it should, literature say that we should, but it didn't. So that's it, that's a reality.
So for systemic photobiomodulation to treat the infection and the acute COVID, seems like the earlier you intervene, the better.
Yeah, up to 7 days. Yeah.
Right.
Yeah. But now with the Omicron, I really don't know. I think, it's probably the Omicron is only affecting the upper respiratory tract. So it doesn't go down to your lung where, the severe endothelial damage and the cytokine storms are taking place, because it becomes systemic. So I think Omicron is actually much easier to treat. But now we're moving on to long COVID. So, these people have already had the endothelial damage. A lot of these guys, actually there's correlation between those who have been hospitalized in ICU. Almost all of them, actually have long COVID symptoms. A lot of it they still have the smell, the loss of smell and taste, brain fog, and post-exertional malaise, tired when they do even thinking or even moving around. So it's still there. So I don't think you see too many people with Omicron, but a lot of these are affected by the Delta variants.
Lou, I see another question from Stephanie.
Hello, my name is Stephanie. Thank you very much for the presentation. The data seems very promising. I had this question which was partly answered, but I just wanted to ask to make sure I understood. So for there is evidence patient has improved brain fog in relation to long COVID, and currently your efforts are in establishing some more specific protocols as well, such as ranges of wavelength and maybe locations of irradiation. So for now, we're not certain specifically which wavelengths would help more, but that's a future goal, if I understood correctly.
Yeah, we are, for the long COVID, there are reasons why we stick to 810. I mean, you can debate whether 810 or some other wavelengths and so on is better. But from our work so far, we see 810 gives the, even through the evidence in the biochemistry mechanisms that, that's particularly dealing with, say, activity of the calcium ion, 810 seems to be the one. So based on what we know and discussion with some other people like Juanita Anders, we are for the time being we're sticking to A10, and A10 is within the action spectrum that's produced by when Dina Kuru did the studies on where the action spectrum are, is 808 nanometers for laser was what was there, so we stay with that. Now, whether another wavelength works better, we don't know, but we don't have time to investigate. We just want to get it out there. Now, the other reason that we just stay with that and make it simple, and is because we are, it's going to be home use. It's going to be easy to use, and it is the other important thing for us is whether we can do a double blind, we can do a sham device. So we have special mechanisms in the clinical trial device that when the person puts it on, it switches off, so they don't know whether they're using sham or real. Now, could we have used the other one, the one on the chest? I think maybe, yeah, maybe for long COVID is going to help. And I mentioned briefly last week that, but we can't do a double blind with that because anybody can see that whether they're using a real or a sham device, right? So unfortunately, we have to compromise and just use one on the head and the nose. So that's a reason for it. And hopefully, the way we located it, my personal opinion, the two most important modules are going to be one in the nose and one in the back of the head.
So how can, I see a question from Marnie. Marnie, go ahead.
Oh, thank you. I really just had a quick question, comment. I wanted to make sure that when you take into account the subjects with long COVID or with Alzheimer's disease who are coming into your research studies, I wanted to make sure you're aware, according to Nadergaard's lab, the lab in the country about glymphatic drainage, that in normal aging, and even worse in dementia, there is very inefficient glymphatics drainage as people get older. So I would be very careful to maybe stratify your cases, not just over 65, but I would maybe go 65 to 70, 70 to 75, because you can get into really big time complications if you're all dealing with even normal aging and glymphatics drainage. And I think we saw this in our football players paper, which I'm still about to get, submitted again, because we did find significant improvement in cognition and behavior and mood for the football players who we were treating. They were age 55, 57, and even 65. And they had significant improvement, 2 standard deviations on cognitive testing, at least 3 to 6 tests. But our 74-year-old case did not go 2 standard deviations improvement on 3 tests, our minimum criterion. He only went 1.5 standard deviations. So it's something to keep in mind. I am really thinking you need to focus on those ages over 65. Anyway, that's all my comment on it. Thanks.
Well, we're saving ourselves a headache and not recruiting people above 65.
What did you say?
Our screening, we're not recruiting people above 65.
Oh, you're not at all. Oh, I didn't realize that. Well, that makes it easy, doesn't it? Well, what about your Alzheimer's study? Don't you have one of those too? I mean, what are you going to do with that? You're talking long COVID. You're not going over 65. Okay, well, Alzheimer's is really big over 65.
Yeah, it's a good valid point, Marnie. We will we're revising that study, and so we'll take that into consideration, stratified by age.
Yeah, okay, fine.
Because right now you recruit 50 and above.
Oh, I see. Okay, so I just wanted to get that out there. Besides, maybe I don't know the thickness of bone is going to make any difference, but who knows? Somebody else knows a lot more about that in aging than we do. I do. That's for sure. Thanks.
This follow-up question here is, so if anyone is interested in helping out, how can the community be helpful to your endeavors, whether it's in long COVID or in the Alzheimer's?
Yeah, I think we will need help in recruitment and actually investigators, moving forward. We're trying to get it off the ground as quickly as possible. We've been discussing about this ever since we were still doing the other study. So, and we were watching out and how we can move the data, use the data that we had, and apply it to the next phase, because at that time we already there were already enough information coming out that said long COVID is going to be a problem. So yeah, and now we're there. I think the next thing is to we're going to need quite a number of investigators for this. We're going to. It looks like we're going to be recruiting again 280 people all over the US actually.
So I assume just reach out directly to you and CB kind of on the wait for a new study and apply to become a site.
Yeah.
Good. Those are two very important studies.
There is a question in the chat from Frederick.
Sure.
He's asking, does the study of long-term COVID suggest that Alzheimer's disease may have a viral origin? That was his question.
Well, I mean, this is one of the theories, right? I mean, there's so many theories about Alzheimer's disease. But one thing I learned from our experience is there's very often a trigger, to get into actually, people have this APOE4 allele. The more copies you have, the more likely you get Alzheimer's disease. But again, it's in the literature, and this is also my experiences. There are people with beta amyloid walking around with no problem, even with the APOE4 or the APP as well. And I remember one case, and Anita Soma is not here with me, but this was actually after our first study, and we looked at this person who was actually a professional opera singer, and he lost all his capabilities because of Alzheimer's disease. And the wife told us that actually it was triggered because he was also an alcoholic. It was triggered when he fell. He had a brain injury. And after that, it was like downhill. And if you look at the literature, it could be triggered by infection. I don't know, even if you get meningeal bacteria going to your brain or whatever it is, which is an infection. It could be a virus infection or whatever. It seems to be, in many cases, to be triggered by something. So it's a theory.
There's evidence for that, Lou.
There is evidence, right?
There's the TBI, the incidence of TBI increases the likelihood of developing early onset dementia by 4 to 8 times. So this is absolutely connected.
There is also recent evidence, actually. It was, again, very recently published, maybe within the last couple of weeks, that that COVID actually triggers Alzheimer's disease. There's correlation between. I think it's a very recent study. So COVID can do it,
I know we are at the end of our time. I don't know if there is any quick question, maybe one, or otherwise we can wrap up. Marvin, did you want to say something? No, all good.
Just thank you, Lou. This was great. Really good information.
Thank you.
Yes, and best of luck with these 2 studies. Very exciting. And thank you all for contributing as usual. Take care. Bye now.